Good morning. I'm Jessica Lovell, and we are live from the Dolph C. Simons Jr. Family Broadcast Studio at our Olathe campus. Welcome to the Morning Medical Update World Cup Health Coverage. The University of Kansas Health System is the official medical services provider for the Kansas City World Cup 2026 host city. Today, we are discussing the 4th of July celebrations ahead for all of us and our visitors. And every year, we caution the dangers of fireworks and burn safety. Joining us this morning is Director of the Burnett Burn Center, Dr. Julia Slater. We also have Kansas City, Missouri Fire Department Public Information Officer and Battalion Chief Michael Hopkins. We also have back with us Dr. Dennis Allen. He is Venue Medical Director and an emergency medicine specialist with the health system. Plus, we have Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Be sure, if you have any questions for any of our guests this morning, submit them on the chat on YouTube or Facebook. And please let us know if you're a reporter by sharing the media outlet that you are with. Dr. Slater, good morning. How are you?
Good morning. I'm great. How are you, Jessica?
Very good. Well, let's start with you. What are the most common injuries that you see over the 4th of July holiday?
Yeah, I think most of them are going to relate to firework usage during this holiday. Certainly we see a little bit of grilling, some bonfires outside, but the majority are fireworks. And what we're going to see is going to be a combination of skin burns, either from touching hot fireworks, fireworks touching or falling into someone, or lighting fires with the fireworks that then lead to burns. Traumatic injuries, so things like fireworks that detonate or explode in hands or near parts of the body, or eye injuries from fireworks being too close to the eye or actually exploding near the face.
Well, we know that kids love those sparklers, and they seem harmless, but what are the real dangers that concern you?
So sparklers, I feel like a lot of people don't recognize how harmful they can actually be. They get extremely hot, over 2,000 degrees Fahrenheit when they're burning. And so obviously if you touch that just after it's been lit or even while it's lit, that is an instant full thickness burn. And you know, they're just available even at the grocery store, and it seems like it's something that's so benign and fun, but they're actually really dangerous. And if you wouldn't let your child that close to the stove, certainly you wouldn't let them that close to something that hot.
Yeah, what could go wrong with kids running around with sticks on fire with each other, having a good time? You mentioned this, though, Dr. Slater. People, of course, are firing up the grills. What precautions should people take, and what should they do if they get hurt? And I would assume the same goes for fire pits as well.
Yeah, absolutely. Kind of both are the same. You want to keep a lot of the same precautions we recommend for cooking inside. So making sure that pets and children are at least 3 feet away from all hot surfaces, whether that be the grill or the fire pits. Avoiding using accelerants when you're lighting them, making sure everyone's back as you are getting it lit. And, you know, we want everyone to have a great time and be responsible. So if you want to include some fun beverages with your party, just do your grilling, do the fire first, and then enjoy later when it's safe.
Yeah, use your head. Yeah. So big birthday year for America, the 250th. Do you anticipate higher volume of injuries? And if so, how are you preparing for that?
Yeah, I mean, I think it's just the perfect coincidence, right, that we have the 250th anniversary and the World Cup here right now. Both very exciting events, and both the potential to increase the injuries that we could see. I think my job as director of the Burn Center has been to make sure that we're prepared in case we do see more injuries. We've certainly done a lot of work of prepping all of our staff and our emergency department colleagues as far as what to do if we see a lot of patients coming in at once. We've upped our staffing to help move patients through quicker, but we certainly hope that everyone's just going to have a responsible and fun time, and we won't see it, and we'll just be prepared for nothing.
Perfect. That would be the perfect weekend for you. Dr.
Yes.
Slater, thanks so much. Stick around for community questions if you would.
Absolutely.
Chief Hopkins, same question for you. Good morning.
Good morning.
Do you think that this bigger celebration year, that of course you add the World Cup into it, do you think that's going to translate into more calls for you all?
We're not really anticipating more calls. We have a lot of calls during the 4th of July weekend and really the week leading up to it and week after with fireworks. We don't really anticipate that there'll be more this year. We expect that the sanctioned events, the larger displays, will obviously attract more people to show up this year.
Well, we know different countries have different rules when it comes to fireworks, so we researched the countries who are base camping here, and this one's pretty interesting. Algeria's U.S. Embassy has issued a strict diplomatic warning order to fans to completely avoid bringing or lighting off any fireworks due to the hundreds of thousands of past fines that they have received from FIFA. Chief, what concerns do you have for people who have very little experience with fireworks?
The same concerns we would have with anybody is that they're using them safely. Obviously, here in Kansas City, fireworks are illegal. It's against city ordinance to shoot them off. But as we all know, that still occurs. So our concerns for someone who doesn't have very much experience is the same concern we'd have for somebody who shoots them off every year, is to use them safely, follow the manufacturer's instructions for how you light them and how you use them. As the doctor was saying, we see injuries every year, traumatic injuries to hands and facial burns, loss of eyes. So just follow the instructions, be safe with them if you find yourself in a situation where you're setting off fireworks.
Seems like an obvious one, but talk about homemade fireworks. Can you explain why that's just an obvious no-no?
Yeah, that's very dangerous. If you're not licensed or certified to build fireworks, it's very dangerous. There's a lot of factors that go into it: weather conditions, humidity, static electricity. At least once or twice a year, we run incidents, maybe not right here in our city, but in our region, where someone catches their home on fire, blows their home up, building fireworks. And that can lead to significant injury and even death. We've had it both ways, on top of losing your home to fire after it goes off. So it's a very dangerous thing to do, and we definitely do not recommend it.
Well, speaking of being prepared, how do you keep your teams prepared and safe for this type of heat that we're going to be experiencing?
Yeah, we're definitely in a stretch of high heat here, as we are always in the Midwest in the summer. We just stress staying hydrated, making sure you're drinking lots of liquids prior to your shift and then throughout your shift, eating multiple small meals to keep your calorie intake up. And then we encourage all of our officers and ICs to keep an eye on their crews, order additional resources early and often when we're out fighting fires in this heat. It's very taxing on the body when we're dealing obviously with a fire, but in this heat, it's compounded for sure.
Chief Hopkins, thank you so much. Stay with us. We're going to have some community questions for you, I'm sure.
Okay. Dr.
Allen, good morning. How are you?
Good morning. How you doing?
Good, thanks. Okay, so we just mentioned visiting teams with base camps here in KC. They may have limited experience with fireworks. What concerns does that bring for you and your teams?
Well, I think mainly it's to understand the danger of these handheld. The things that you may not be used to, that you're holding them in your hand, you light them, you think you're going to throw them, and they go off in your hand, and we see such terrible injuries from that. We've had people, we've had professional athletes lose part of their hands from trying to do that. So just to understand that even something that looks fairly innocuous can be a pretty dangerous thing to be handling as far as fireworks.
Well, in celebrating the wins at KC Stadium, we've already heard fireworks go off around the city. Are you seeing any injuries yet from post-game time celebrations?
No. It's just been the usual, a few injuries, nothing we haven't, not particularly from fireworks, nothing we didn't anticipate.
Well, you mentioned the handhelds. Any other fireworks or any other things that pose really big dangers over 4th of July weekend that you want us to be aware of?
Yeah, I think that the big ones, people see big fireworks go off and they think it looks really neat, and they try to design their own way to shoot off these mortars. And man, that is so dangerous. You don't know when they'll ignite. If they're not in the hands of professionals, they can be really dangerous. We've even had a few patients that a mortar didn't go off, so they tried to look down the tube to see what happened. And naturally, that's when it went off. These big, neat, light up the sky fireworks should be in the hands of only in the hands of professionals.
For sure. Dr. Allen, I want to talk the weather because we knew this heat was coming for us. We've been talking about it since the game started, but today it should be about 94 degrees Fahrenheit, 34.5 Celsius, heat index of 103 degrees. This heat is expected to stick around through the weekend. What do you expect to see as far as heat-related concerns now that we're seeing these higher temperatures?
Well, I think just statistically, we're going to see more patients who just need to get out of the heat, who just need to cool down somehow, and we've been ready for that since the game started. So I think that is just going to increase now. We're even ready in our player medical center if it's a player that has a problem of excessive heat. So. We expect it, and we've been ready for it since the game started. We've just gotten a break from the weather so far.
Okay, well, with the heat, we're looking for some good cooling down hacks, Dr. Allen. So do things like cooling towels work? Where's the best place on your body to place it? Just what can you tell us about little ways to stay cool the best we can?
Yeah. They absolutely work. And probably the best places are your head, your neck, and your arm, and under your arms. Probably the best places for it. And they work. They absolutely work because you get some nice evaporative cooling. And really cools down your body can lose a lot of heat that way.
Great advice, Dr. Allen. Thanks so much. Stay with us for questions.
Well,
Dr. Dana Hawkinson, good morning. How are you?
How are you?
Good, thanks. Okay, so whenever any of us check in for an appointment here at the health system or anywhere else otherwise, we are asked if we have traveled outside the U.S. in the last 30 days. Should we be answering that question differently if you've spent time at the games or at FanFest?
Yeah, that's a good question. You know, again, this travel screening that we have at our clinics and our hospital when you're admitted or come see your providers. We've had this in place for quite some time. It is one of the levels of protection that we are offering for infection prevention and control, just to do that travel screening and ask if there's any increased risk if you have traveled anywhere. Right now, we continue to do that, but if you are out in the crowds or at a fireworks event or going to watch parties or anything like that, there's no reason for increased risk at this point that we can see. So that really wouldn't change anything at this point. It's really just those travel questions that we're asking about, not necessarily events locally or really anywhere else in the United States at this point.
What are public health departments keeping an eye on?
Yeah, I mean, I think common things are common. Again, we know what is going on globally. Of course, we know about the Ebola outbreak going on there in Uganda and the DRC. But really around here, around our community and in the United States, it continues to be those common things. We are always monitoring for respiratory illness, although that is quite low right now as we are not really in respiratory viral season. But also GI illness is vitally important. Things like norovirus, hepatitis A, rotavirus, those types of things that can easily spread between people and groups, especially if they are eating and doing things of that nature in close contact. And again, most importantly, not washing their hands adequately and having that hand hygiene.
Well, we have some questions coming in. Hawk, thanks so much. Yeah. Angie has a question for Dr. Slater. She wants to know what types of fireworks cause the most serious injuries from your standpoint.
Yeah, I think Dr. Allen already alluded to this greatly. The bigger the firework, the more damage it's going to cause, especially if it ignites or detonates close to someone. So as you get to those larger exploding, the ones that go up into the air, those are the ones that have the most risk of causing not only burns, but the more traumatic injuries where people lose limbs or can possibly even die.
Janine wants to know if fireworks cause an eye injury. How do you handle that?
Yes, I mean, same way as anything else. The first thing is to not panic. If anything on or near your face is on fire, to get that out, remember to stop, drop, and roll. But you want to try to gently cover the area on your face or your eye with a cool, clean towel and get someone to the emergency room as quick as you possibly can.
Dr. Allen, Alex is asking, what if you're outside in the heat and all of a sudden you feel cold? I heard that was, he says he heard that was a good indication that you're going into, maybe a possible heat stroke.
Yeah, it's kind of an interesting process that you sweat when you're hot because you're delivering more blood supply to your skin. And then as you get dehydrated, the blood supply leaves your skin and you just feel cool and clammy. It's kind of interesting. So what it's telling you is you're getting into the next stage of dehydration and into a heat-related illness. And it's time to get hydrated. It's time to get out of the heat.
Chief, Jill has a question for you. Have you had to respond to any house fires due to fireworks this year in KC? She says over the weekend, someone in Olathe caught their deck on fire.
At least any that have been confirmed by investigation that we've run any that are strictly due to fireworks. However, we run them every year. We're bound to at some point here over the next week or so.
All right, and last question, Chief, is for you. If we are going to be shooting off fireworks ourselves with family and at our homes, is there anything that we should have handy?
Yeah, if you have a portable fire extinguisher, always keep that close. One of the biggest things we see alluding to those house fires is when folks clean up the debris afterwards, they just throw it right in the trash can. That trash can's sitting next to the house, or that trash can's in the garage. Typically, when we run that house fire, that's where it starts. We suggest having a 5-gallon bucket, preferably a metal one, full of water. Put all that debris in that water, let it soak overnight before you get rid of it.
Great advice. Thank you so much. Well, we have you covered at the World Cup, bringing you the very latest health updates on our live shows every Monday, Wednesday, and Friday right here at 8 a.m. Our next show focuses on heat and the greenhouse effect. We'll look at how hot cars can get. That's on Monday. We've also put together convenient videos to help with everything from emergency care to staying healthy in the heat, and even some travel tips in there for you. You can find those on our website. That information is on your screen. Today's video is on fireworks safety. Then on an encore edition of Open Mics, we take a look at CAR T-cell therapy and its impact on patients with blood cancers. Once considered a last resort option, this groundbreaking immunotherapy is giving new hope to some patients with leukemia, lymphoma, and other blood cancers. Hear how it works and the life-changing results it can provide. Thank you so much for watching.
Every year, doctors treat thousands of patients for burn injuries, and fireworks present an increased risk to life and limb. I'm Dr. Julia Slater, a burn specialist. I have advice for preventing a fireworks injury and what to do if you get burned. It's best to leave the fireworks to trained professionals, but if you opt to light some of your own, keep a bucket of water handy. Find an open space away from trees or buildings that might catch fire and spread. Do not hold a lit firework, and don't try to relight a firework that didn't ignite. Do not let children handle fireworks. Even sparklers burn at 2,000 degrees Fahrenheit, enough to severely burn the skin or catch clothes on fire. Use a safe alternative like glow sticks. Should your clothes catch fire, remember, stop, drop, and roll to put out the flames. In case of a burn, take off any jewelry, watches, and clothes to prevent skin from being further damaged. Cover affected areas with a dry, clean sheet or loose bandages. Then seek immediate care. For small burns, treat the affected area with cool, not freezing cold water to stop the burn and reduce swelling, avoiding ice. After rinsing the wound, use a bacitracin ointment and apply a non-stick bandage or dry dressing to prevent infection. Drink fluids and treat with over-the-counter pain medication. Change bandages regularly to keep the wound as clean as possible. If a burn blisters, is larger than your hand, or is pale and leathery, you need to seek immediate professional care. Remember, the best treatment is prevention.
Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System and Executive Vice Chancellor at the University of Kansas Medical Center. Hope you're having a great day. This is an Open Mics program. We're back with me, Dr. Stites. Today we're looking at how far we've come in treating multiple myeloma. It's the third leading blood cancer. When I started in medicine, it was a deadly disease. Today, the American Cancer Society reports that 1 in 132 people at risk of getting multiple myeloma in their lifetime, with seniors being the most at risk. And the blood cancer develops when plasma cells in the bone marrow multiply uncontrollably. Today's guest is currently showing no signs of cancer thanks to one of the most cutting-edge treatments in oncology, CAR T-cell therapy. It represents real hope, and sometimes we can call it a cure. Sherry Kennedy, a longtime University of Kansas Cancer Center employee, once helped patients fight cancer until she became a patient. Today, she shares her remarkable 17-year journey from diagnosis to remission.
It began in 2007, a strange feeling at work Sherry Kennedy couldn't explain.
I couldn't use my left hand, and a couple of months later found out there was a big tumor there eating on my bone.
Tests confirm multiple myeloma, a rare blood cancer.
What in the world is that?
Sherry started treatment, radiation, chemotherapy, and later a stem cell transplant.
They say it's going to make you really sick, we're going to almost kill you, and then we give you your cells back.
After brief remission, the cancer returned 4 times. By 2021, the doctors at the University of Kansas Cancer Center recommended something new, CAR T-cell therapy.
If an 11-year-old with leukemia can do it, you can do it.
Dr. Roy Jensen, who worked with Sherry for years, says her case came at a turning point for cancer research.
She received CAR T pretty early on. The early results had been so incredible. That trepidation was largely replaced with kind of relief and hope that we would have something that would really be able to make a difference.
Now, nearly 4 years later, Sherry's in complete remission. No infusions, just labs.
It made me able to sit here and talk to you today and tell you about it.
She credits science, faith, and never losing hope.
Find a specialist, make sure you have support, and don't lose hope. Hope is always out there.
Sherry Kennedy is joining me in studio today, along with 2 blood and bone marrow transplant experts. Dr. Joseph McGurk is the Director of Hematologic Malignancies and Cellular Therapeutics at the University of Kansas Cancer Center. Also, Dr. Alaola Abdallah, a multiple myeloma specialist in hematology and the medical director of plasma cancers. Gentlemen, welcome back to the program today. Sherry, you shared that you never lost hope. How did you stay so positive and so motivated?
Well, I had great support from my family. My daughter, my sister, and the staff at the Cancer Center was very supportive.
Yeah, that's a really big deal. And having that new treatment, so talk to us a little bit about that. Dr. McGurk, rare blood cancer, tell us the story.
Yes, absolutely. It affects about 13,000 people a year in the United States. And it's a terrible, devastating disease historically, attacking the bones, as Sherry mentioned, forming tumors in the bones, and sometimes in organs the tumors can form. They fill up the bone marrow with a bunch of cancer cells, can cause terrible, debilitating pain, kidney damage, and ultimately bring about the demise of our patients. Historically, when I started out in the field, median survival was 2 years. Game changer, completely different story today.
It is a different story. And Sherry, you worked with a friend and colleague of ours who we just saw in the video. Dr. Roy Jensen is the director of the University of Kansas Cancer Center. What was your role in the cancer program?
Oh, my first job was one of my favorite jobs in my life. I worked for Roy and really learned a lot about just cancer, how to spell some of the diseases too. Then I transitioned to the clinical trials office, learned a lot about that, learned how to spell a lot of the diseases too. So,
you know, that spelling thing is kind of a challenge because these guys keep changing the spelling and they keep changing the names. And like there's like Lucy in the football with Charlie Brown, you know what I'm saying? Now, Dr. Jensen couldn't join us today, but we asked him about when he found out you were diagnosed.
Our reality is that we take care of somewhere between 7,000 to 8,000 new cancer patients a year. And so those figures are almost mind-numbing. And But what kind of jolts you into reality frequently is when someone who's been part of the family, has been part of the inner circle for literally years, you know, they come down with a diagnosis. And, you know, and it does set you back, but on the other hand, we understand that there's no better place for them to be. And, you know, things have changed dramatically over the last 20 years in terms of the therapies that we offer and the effectiveness of those therapies. And so it's great to be able to offer hope to any of our patients. But obviously there's something special about, you know, somebody who's been part of the family.
You know, that's a pretty good testimonial, and just to say it means you've got your foreign language certificate and all these names we have, and can spell and say it. Well, speaking of those new therapies, Dr. Abdallah, you convinced Sherry to undergo CAR-T therapy. It's one of the biggest developments in cancer treatment in decades. The University of Kansas Cancer Center was the first and only site in the region to offer. Now, I'm not going to say this. You're going to have to say it. What's the word?
Oh.
This word,
Abecma.
Okay, CAR-T cell therapy to treat multiple myeloma. And so tell us a little bit more about that and some of these words that we
Absolutely. And we have to understand exactly this really is a very important development of CAR-T cell. And Dr. McGurk, you know, have been actually one of the first pioneers in KU to bring the CAR-T cell prior to the myeloma to acute leukemia and lymphoma. And I think the importance about that is that we are redirecting ourselves to change how we treat myeloma to immunotherapy. So taking your T cells and putting what we call a CAR, or I call it a laser tag, that we target the myeloma cells. In our myeloma cells, we have a target called BCMA, which is present in 95% of the times. So that is a very important thing, you know, for this CAR-T cell to recognize these myeloma cells. After we, you know, make or manufacture these CAR-T cells and make millions of that, we reintroduce it to the patient after we give a small dose of chemotherapies over 3 days, and these CAR-T will go to the to the body. Wherever there is a myeloma, it will attach to it, and like any other T cells that attacks the infection or any cancers, if they find it, it will produce cytokines, and I call it like bullets. Will attack the myeloma cells, kill the myeloma. The response rate of the CAR-T cell, and Dr. McGurk can agree about that, is really amazing. You're talking about one single treatment for patients who receive multiple lines of therapy was over 80–85%, you know, in a very high dose. And that was very impressive because we're not talking about just response rate. We're talking about a one-time treatment. So when we saw these results, we were very excited about it, especially like the historical results of prior to, you know, for standard care treatment or any drugs was barely 20–30%, and we moved to 80%. So that was a big and a huge jump using this CAR-T.
So let me get this right. You take the cells out, you reprogram them, you do something, and then they go play Stormtrooper and laser tag, and they kill the cancer, right?
Correct.
So really it's kind of like magic, only it's real, and we call it science. It's like it might have it right there, folks. All right, so why was this the right choice for Sherry? Tell us about what made her case in particularly amenable to it.
Absolutely. I mean, unfortunately, myeloma in the majority historically have been an incurable disease. It's like diabetes. Your myeloma is going to come back again. Every time you have a treatment, you know, you can go to remission, but you can't stay in remission every time. And that, you know, length of remission shortened down. So we really needed newer treatments, and the CAR-T cell came on the time that, you know, Sherry was actually relapsing, and she met the you know, the criteria for actually receiving the CAR-T cell. Newer treatment, and not only that, the quality of life that we talk to patients about it, because Sherry had been on multiple treatments. She had to receive the treatment either weekly or monthly coming to the cancer center. You're talking about a CAR-T cell treatment. Well, I mean, in the past it used to be inpatient, but Dr. McGurk and his team are able to do most of the treatment outpatient. So we're talking about a good quality of life for patients receiving one-time treatment. Do not have to come weekly to receive any IV drugs or any oral pills every time. So quality of life versus efficacy, these two were actually magical, you know, terms for patients like Sherry.
So let me just get this straight. You're giving Stormtroopers as an outpatient now?
Yes, absolutely. That's right. We have the infrastructure at University of Kansas Health System to be able to do that 24/7. We're there to back those patients up immediately.
Yeah, that is remarkable stuff. Now, Sherry, do you remember what this conversation was like and how, after Abdallah explained this treatment to you, and what did you think?
Well, to be honest, he worked really hard on me to push me into it, along with Dr. McGurk. And yeah, it was interesting. I didn't understand what he was going to do. I really didn't, and I love the science of it, but I didn't understand it. But he kept pushing and worked on me. And at that time, more things were happening with CAR T-cell.
Okay.
Yes, it was very, very exciting. Very scary, but very exciting. But I do like what he said about quality of life.
Yes.
That's what I was after.
Yeah, and it sounds like you've achieved that and received that, right?
I have.
From this, this magical therapy.
Magical, right.
It is. Dr. McGurk, you've said it's one of the most stunning advances you've seen in all your years of practicing medicine. I would agree. What's the future for CAR T look like?
It's an extraordinary future. You think just about multiple myeloma, to take a step back for a moment, as Dr. Abdallah was describing. We take patients who have failed every other therapy known, multiple myeloma, and in one of the studies with the longest follow-up, 98% overall response rate, 82% complete remissions, and now we have 5-year follow-up showing that a significant percentage of patients are still in complete remission, and many in our field, including me, and I think Dr. Abdallah, believe that that's a curative therapy. We've never seen these kind of results in any type of blood cancer that we've treated historically. But we have a lot of work to do yet. Not everybody responds, not everybody who responds stays in remission, and it can take a toll. There are toxicities associated with these therapies. So not only are we refining things in multiple myeloma patients and other types of blood cancers, but as you know, in our center, we're moving into solid tumors now with early clinical trials to start attacking a broad array of cancers.
So you're coming after cystic fibrosis next because, you know, my patients still could use a little more help with their disease.
I can't speak to that, but I can speak to autoimmune disorders and neuromuscular disorders that are part of the immune system. In our center, as you know, and around the nation and the international community, we are exploring CAR T cells in those settings and seeing some very promising early results.
What are some of the toxicities like?
When those CAR T cells attack, they attack, as Dr. Abdallah mentioned, when they attack the flu, and you have the flu, the reason you feel lousy isn't because of the flu virus itself, it's the immune system's response and all of these cytokines that attack that flu-infected cell. Same thing happens with cancer. So when you take CAR T cells and you give them to the patient, you infuse them into the patient's blood, they go after billions of cancer cells, and it can cause flu-like symptoms times 5.
Okay, so you're feeling kind of crummy, but only for a while. And
that's right.
Can you ever do CAR T cell therapy a second time?
It's a great question. And so for those patients who have relapsed, we have been doing different types of CAR T cells and seeing some remarkable results. Indeed, we're making a CAR T cell here at our institution in our laboratories that recognizes not just one target, like Dr. Abdallah mentioned, BCMA. Those cancer cells are smart and they can pull that molecule off their surface and become stealth, and the T cell can't see them. So our strategy is to target 3 different types of molecule. So if one disappears, we're still going to get it.
So I think my thing about stormtroopers is pretty accurate here. I love it. Dr. Jensen agrees. He says we are just at the beginning of the journey on what CAR T can do.
In many ways, CAR T has, in its early stages, has had even more success than, say, like chemotherapy. When it began back in the 1960s. And I think that what it reflects is the fact that we're beginning to leverage a lot of very basic science knowledge around how the immune system works. I think we're just beginning on that journey. And so it's almost surprising the amount of success that it's had already. And as we learn more and are better able to fine-tune this therapy, I think it's going to be revolutionizing cancer care for many different types of cancers, not just hematologic malignancies.
It is a pretty remarkable journey. Do you think you and I could take some of his hair?
I sure would like to.
Oh my God, he's got so much.
Not fair.
No, what happened there? Okay, work on that one next. Right. So as we mentioned earlier, CAR T therapy has been called a miracle drug, and the success of the therapy so far is giving patients a newfound hope. And before CAR T therapy was an option, Sherry underwent radiation, followed by chemotherapy, and a stem cell transplant. Sherry did a tandem transplant, something that was considered aggressive in 2007. A tandem transplant is when you receive 2 doses of high-dose chemotherapy, each course followed by an infusion of the patient's own healthy blood-forming stem cells. The treatments are given weeks or months apart, but are usually completed during a 6-month period. Dr. Abdallah, walk us through what's changed in treatment over the last 18 years. Do you still do these kind of tandem transplants? Why not just go right to CAR T?
That's a great question, and I think this is a very important thing to, as Dr. McGurk say, in 2 years survival to now over 15 to 18 years, and we're hoping that we're going to start seeing cure. The reason of this shift happened because we're changing the way we are thinking how we treat myeloma from traditional chemotherapy now to more targeted therapy, and now we have the cellular therapy. The last 5 years we have seen all the cellular therapies evolved, and we have seen approval 2 CAR T cells and 3 bispecific drugs. This is a very important thing for our team to understand exactly like how much that really helped us a lot in terms of like how to treat myeloma. Not only we're talking about keeping patient in remission, but also we'll talk about quality of life, because 2 tandem transplant, that's really tough, for patients. And we stopped doing that years ago because we have great treatments right now. We have immunotherapy treatments, and I think the replacement of the stem cell transplant happened very quickly. Now, we're talking about tandem transplant. Now, the big question is everybody's asking, and Dr. McGurk, we have a little bit more debate about that. Can CAR T cell replace transplant? We do have a clinical trial that want to compare between CAR T cell versus transplant in newly diagnosed myeloma. We do have to understand that transplant have been there for years and years. It has been impossible to beat it, but maybe CAR T cell this time with the newer event can actually do that. We will know that through the clinical trial. So off the clinical trial, we do not do a CAR T cell up front, but in clinical trials, we do have a clinical trial that we can actually compare transplant versus CAR T in newly diagnosed myeloma.
That is going to be so cool. Wow. What's going to win?
Yeah.
That's going to be therapy.
Yeah, that's going to be a big match.
It is going to be a good match. All right, so Dr. McGurk, over the last 2 decades, treatment results have improved considerably, largely because of a number of new myeloma drugs that have become available. CAR T therapy worked for Sherry, but maybe it is, but sometimes it's not the right choice. Who would benefit from CAR T? Who do you think would benefit from some of these newer medications, and are all these trials going to give us the answer?
So these new drugs are remarkable in and of themselves, as Dr. Abdallah was mentioning. We're seeing complete remissions with what we call novel drugs in combinations. And so the current standard of care in the United States is novel drugs followed by stem cell transplant followed by maintenance therapy with some of these novel drugs afterwards, and that's made remarkable progress. As Dr. Abdallah mentioned, our strategy currently is to challenge stem cell transplant. We never want to get completely wedded to any given technology. I'm a stem cell transplant doctor, but my focus and goal is to come up with the most effective therapy for patients. So CAR T cell therapy, and I think and I predict it is going to replace stem cell transplant in the years to come. We have a ways to go, and we're conducting the studies now. And so the current strategy is upfront immunotherapies in different forms and new drugs, followed by stem cell transplant, followed by the maintenance therapy. I envision CAR T is going to supplant stem cell transplant, but the bigger question is, do we even need these novel drugs? Can CAR T cell therapy do this work up front as first-line therapy for patients with these diagnoses? And that is going to be explored over the next several years.
That is amazing. And Dr. Abdallah, multiple myeloma is incurable in most cases, but remission rates and survival have really improved. What research are you following that has you the most hopeful?
I think one of the research that Dr. McGurk already mentioned is multiple targeted. I think that's going to make a big change. And Dr. McGurk has mentioned about one of the studies, the long study, which is very impressive. In relapsed myeloma, we used to tell patients there's no way you can go to remission and stay in remission for above 2-3 years. You're lucky for that. We're talking about 5 years after one treatment, staying in remission in 30% of the patient. That's that's really big, and that was a definition of cure in the myeloma field, And I think we can increase that percentage. And one of the theories I have is that, as Dr. McGurk was saying, multiple target, like not only the BCMA, maybe GPRC5D or maybe another one that can actually increase that targeted from curing myeloma in 30% up to 50%, which is still great. You know, you're talking about the patients that we used to tell them that your myeloma is definitely going to come back again. No, you have a chance that you can your myeloma can be cured. That's one of the research studies that I think it's going to be a major impact. The other one, which is, although it's earlier, we call the in vivo CAR T, and which means, like, you know, you don't need to take the CAR T out. You know, you just re-inject the virus, you know, and you have the CAR T built inside your body. So this is kind of like going to be huge because it's going to be an access and available for a lot of patients. And I think these two things are going to make a big impact in the CAR T world.
Yeah, that is amazing. Dr. McGurk, your thoughts?
As mentioned, doing what's called in vivo CAR T development. We just had a meeting at 7 a.m. this morning, and we are one of just 8 centers in the nation that are going to open a clinical trial doing just that, and that is injecting what we call the vector to get those genes into the T cells inside of the patient without having to take their cells out and manipulate them in the laboratory. Very early exploration, but it's gee whiz science, an extraordinarily promising future. You know, I've always been excited about cancer medicine and cancer therapeutics and the potential, but now at this stage of my life, this is by far the most exciting time of my entire career, and I think many, many hematologists, oncologists would tell you that that's the case.
How can you not have faith in science when you see the difference that you and I have had in our careers?
Absolutely.
How can people constantly say, I'm going to go try all this other alternative stuff, when you see that myeloma patients today are alive who yesterday died?
That's right.
I mean, it is a remarkable, you and I have been in medicine so long, and we were doing rotating tourniquets back when I started for heart failure, and just watching people have heart attacks and people with cystic fibrosis when I started, lived about 5 years. And now, it's so different. And it's science that's changed us.
Yes, absolutely.
Yeah, it's amazing. Okay, we're here to answer your questions. Send them using the links on your screen to YouTube, Facebook, or email the Medical News Network. All right, let's check in with Doc Hawk.
Yeah.
All right. There's a new nasal vaccine for bird flu. Talk to us a little bit about that.
Yeah, I think we need a nasal vaccine for science misinformation and disinformation, really. So I'll start out by saying that, you know, avian influenza, so there are multiple types. Most recently, the H5N1 type has been circulating around the globe for the past couple years. We've really known about human infections really since the late 90s. That has occurred. There's been no real sustained human-to-human transmission, although there was a recent article just published that there has been silent human transmission, more than we know of, recently with this new H5N1 that has been circulating. But, you know, what do we do? What do we have for protections? Well, there are 3 licensed vaccines for protection. The U.S. has made stockpiles of those. Certainly know in one of those northern European countries, they were allowing some of their residents that were a high risk for it to be able to get vaccinated against H5N1. Recently in the news, however, there's been a new intranasal version of an H5N1 avian influenza virus vaccine that has been tested. Again, it is very early. There are still a lot of steps to make it to the market, make it available for people, but it is a very early phase 1 trial, just showing that it may have some efficacy, as we've seen some broad protection from this vaccine. So overall, I think it's too early to tell, but you know, we are working to create protection and protective methods against avian influenza in humans. Right now, luckily, there is no sustained human-to-human transmission, but we know that many cases can be fatal, so it is important, and there always is that potential for avian influenza to become the next pandemic. However, again, we've known about human infections really since the late 90s. It hasn't gotten there yet, but we always need to be vigilant in doing the investigations and looking, and also creating things that can protect us as humans, and this may be one of those things that can help protect us.
Pretty cool. Now, we've been looking at the benefits of COVID vaccination, and now there's a new analysis regarding teens and vaccinations.
Yeah.
Tell us about what that analysis shows, because I think it'd be kind of good news.
Yeah, this is another recent study that we have seen, and basically what it showed is that vaccination can lower teenagers' risk of developing long COVID. As we know, long COVID is a horrible disease that affects many millions of people every year, or every day actually, in their daily lives. So what this study showed is that the risk of long COVID in these teens can be up to 36% lower in those teens that were vaccinated versus the teens that were unvaccinated and got infected. And basically, long COVID is a chronic condition that can affect multiple organ systems. It has been studied even in our health system. We've done several shows about long COVID as well. But it can affect things like people having brain fog, just having weakness and feeling tired all the time, shortness of breath, muscle aches, joint aches, really many systems that can be affected. And so we know that, we want our children to be protected because, from the disease, but also those long-term effects as well.
Okay, there's another one that I think you've talked a little bit about adolescents 12 to 17, looked at some of those long COVID symptoms. Yeah. Anything else you want to add to that?
Yeah, what I would say is that overall the data from this most recent study was very important in the fact that it showed that unvaccinated patients, so patients that got infected and were unvaccinated, had a 20% chance of long COVID. However, if you were vaccinated, you had a 13% chance. So that is a significant drop in the risk of long COVID. In addition, it also showed that even for severe long COVID, you had a 30% reduction in the chance. And what we have on this graphic shows that how does the vaccine work? Well, the first little red box with the squiggly line up there shows, vaccination can help prevent infection and reduce the risk of infection for a short period of time after vaccination. Next, in that second red box down there with the squiggly line, we also showed that vaccine certainly helps in reducing the risk of severe symptoms of COVID, which is very good as well. Those two things can help overall reduce the risk. And then also the vaccine can help mitigate further inflammatory processes within the body, which may be one of the causes of long COVID as well. We are still trying to investigate the full nature and the mechanisms of long COVID, but it can work in a multifaceted way, getting the vaccine. And this goes to what we have been talking about really since early on after we learned about long COVID, Steve, and the fact that all of the studies really have shown anywhere from a 15 to 30% reduction in a person's likelihood or risk of getting long COVID. This is just one more piece of information, one more piece of data to help support the fact that vaccination does help reduce people's chances of getting long COVID, and that is a good thing.
All right, so Hawkeye, as you think about all this science and you think about the information about long COVID clearly being reduced with vaccination and not having all the terrible side effects that people have made up, what is our advice and your advice to parents?
Yeah, and I'll say my advice is to please get your children vaccinated, and I take that advice, and I've said this before. The reason I do get my children vaccinated against COVID because they are at low risk of severe disease, but the main reason is to help reduce their risk of long COVID so that they can get through their days, they can play, feel well, do their schoolwork, and not have the risk of having those long COVID symptoms in their everyday lives.
All right, we know many of you have questions. Let's head to Studio B. Alexis, good morning.
Good morning, Dr. Stites. We have a great question from Jeremy Yenser. Jeremy wants to know, currently CAR-T is using the patient's own cells, so is there any possibility that there could be universal CAR-T cells from donors?
Ooh, that's an interesting question. All right, guys.
That's a great question. And so we are actually conducting such studies and looking at what we call off-the-shelf CAR-T. Well, some of the things we've discovered about why not everybody responds, not everybody who responds stays in remission, is because the T cells in the patient who developed cancer, well, they developed cancer in the first place. T cells are supposed to prevent that. And so are they the best and healthiest T cells? And then in addition, as we mentioned, patients like Sherry who have received many different types of therapy, those therapies are not just toxic to cancer cells, they're toxic to the immune system and T cells as well. And so would it be better to use an 18 or 19-year-old college student to donate T cells and gene edit those so that they would not cause problems in our patient or be promptly rejected. And there are such studies. We've presented data nationally and internationally at meetings and such studies that we've conducted in different types of blood cancers. And we actually are forming a large network of centers throughout the Midwestern part of the nation under Dr. Gary Doolittle, the Midwest Cancer Alliance, that organization to use off-the-shelf CAR T cells, which we can get the next day and not take weeks to manufacture, as was in the case for Sherry, have them in 24 hours and take them out to our community affiliated centers and deliver the CAR T cells locally to improve access for patients in need. Great question. It is cutting edge. It's exactly what we're doing now.
Lori has a question. Lori wants to know, are there risks associated with CAR T therapy, and if so, what are they?
Most certainly there are risks. The patients receive chemotherapy beforehand. It's really just to suppress the immune system, not to treat the cancer. So the T cells will expand when we infuse them into the patient. That chemotherapy can cause low blood counts. We have to be mindful of that for some time period. They generally recover several weeks after the CAR T cells have been infused. When the CAR T cells are infused and they attack the cancer, they can cause significant flu-like symptoms, which of 95% of are very manageable with the therapies that we have to dampen down the immune system temporarily. But 5% of those patients can end up having to spend some time in the intensive care unit, and very rarely there have been fatalities associated with toxicities of CAR T, particularly in the early years of the development of these therapies. There can be neurological abnormalities that occur, transient, short-lived for our patients, because these T cells go into the central nervous system around the brain and the spinal cord, which is a good thing because cancer cells can hide out there. But when you get inflammation in those areas, it can be very challenging for our patients. Those are the principal toxicities that we contend with, but we have the infrastructure and the team 24/7 and all of our consultants in the institution who are very adept at handling those toxicities.
Jill has a question for Sherry. So Sherry, this one is for you. She wants to know if you got super sick during the treatment like they said you would, or how you felt during the treatment.
Oh, during CAR T, not really. The chemo I took before was a little challenging, but I was in hospital and I had great staff, Unit 41, 42, fabulous people, fabulous. And then I did get sick after that a little bit, got that high fever, and I did take that drug, ketamine, but it helped. It helped, yes. And a few days later, I went home.
So, Dr. Abdullah, one quick question for you. How many folks have you treated now with this CAR T therapy?
That's a great question. I really need to look exactly and see how many, but I think it's like, how many we have CAR T? 600.
Yes.
Yeah.
Really?
Yeah,
That's great.
We're one of the largest centers in the nation.
That's a big deal. And those are 600 people who have a chance to live
Yes,
that
sir.
without science would not have lived. I'm going to do on my really thing. I'm going to invent a new world. IntSci. Don't listen to internet science. IntSci is not real science.
I like it.
Listen to the people who actually do the science. All right, this has been a great discussion. I'm grateful for our guests for being here. I want to hear final thoughts before we go. Dr. Jensen couldn't be here today, but Sherry, he did want to share this message with you.
Everybody in the Cancer Center obviously, celebrates, her success, and we're so, grateful that we could offer her, some hope, and that hope is now translated into something that was probably far beyond any of our expectations at the time, and that's such a fantastic feeling.
Oh, that's powerful, Sherry.
That's really nice. It's very nice, yeah.
All right, Dr. Abdullah.
Well, I mean, I think, we have, a few things to say about that. Always remember clinical trials are the reason why we're right now here, So we encourage a lot of patients, to ask about clinical trials with your oncologist, and to reach out to KU Cancer Center. We have a really great office. We have great trials. Dr. McGurk is bringing the, world-class trials. We're not talking about any kind of trials, and that's very important.
All right, Dr. McGurk.
Yes, so absolutely clinical trials. and get yourself to a comprehensive cancer center like that at University of Kansas Cancer Center. You will be treated by folks who are very, very focused on specific types of cancers, who have an array of clinical trials that will be available to you and are cutting edge. You'll know you're getting the right therapy and you're under the best care possible. Absolutely essential. This is an extraordinarily promising time, but you got to get yourselves educated about the options.
You know, I love to say it, faith, hope, and science. Each of those is very powerful. The faith in science to help us get better. The hope that the research is going to take us to a different place. And the fact that science can deliver. Not the science you read on the internet, but the real science being done by scientists who have taken a disease that had almost 100% mortality rate, and today is a treatable disease in the long run, and maybe we can almost say the word cure. Faith, hope, and science allows us to live long and prosper. We'll see you next week.